Introduction. Are we really ready for prime time? I'd say that we really are at a point in time where we need to change from using our tools which are currently limited to new and next generation technologies, because the old tools put our patients at a disadvantage and lead to expenses that really shouldn't be incurred. The current tools do not allow us to depict the presence and the extent of metastatic disease. So when a lot of us talk about metastatic disease and we say you've got one metastasis, people often have multiple metastases. We know that as we move into this precision medicine paradigm for treating patients, we get a lot more heterogeneity of response. And for metastatic disease, particularly for metastatic bone disease, we are unable to depict the heterogeneity of response. And this has a direct bearing on patient outcomes, and I'll show you that in a second. And thirdly, we're not able to identify patients who are not responding in a timely fashion, which means we don't change treatments in a timely way, and that puts patients at a disadvantage. So I just wanted to illustrate this with one case. So here, for example, is a man with metastatic castrate-resistant prostate cancer being treated with enzalutamide. You can see the PSA is about 45.5. He has retroperitoneal lymph nodes, and this is the red arrows here on this whole body diffusion rated image with a B value of 900. So the bone scan is normal, which is what we'd expect. So you can see that using a conventional tool, which is PSA, the PSA goes down, the lymph nodes go down, and of course the bone scan is still negative. So the tools seem to be working. At week 25, you'll see the PSA is still suppressed, so the tool seems to be working. The bone scan is still negative, but the MRI sees a single bone lesion. Now, we know this is a metastasis because we've got two prior scans. The advantage of the whole body technique, which is what Frederick just said, is that you can zoom in on that area and say, is this a metastasis? And of course it is. Wasn't there 25 weeks previously? PSA is still suppressed, so the conventional paradigm is to keep treating. Okay? So if you then look at week 37, so 12 weeks later, you can see two new lesions have now appeared on the bone scan, but the PSA is still suppressed. So what is the natural reaction of your clinicians? Well, they'll say, there are two new lesions, this could be metastatic disease, but you know, bone scan criteria say that you need to confirm the presence of metastatic disease before you switch the therapy, at least 6 weeks later. Okay? And then the PSA begins to go up, not a lot. Now, there are multiple bone metastases, and look at the volume of disease. So, if you think about this, oligoprogressive disease was at week 25. The time at which we switched therapy was week 50. 25 weeks later, we saw a CC of cancer. Early detection saves lives, correct? We know this. But we didn't switch treatment for another 25 weeks. Now, how many of you, if you had this sort of issue, or your relatives would have this issue, would find this paradigm acceptable? None of you. Not only that, but this drug is expensive. If you look at this, 1 year of treatment is $129,000, right? So in this particular patient, in the USA, you would have wasted 25 weeks of treatment, half a year. 60,000 euros would have gone down the toilet. Why? Because we were using conventional imaging. Many of you will say, but the recommendations are to do CT scans and bone scans, and you are being disingenuous. And you know what? All the recommendations say that, right? Here are 4 recommendations or 5 recommendations. No, the last one is my recommendation saying don't use it, right? So there are 4 recommendations, recent ones, saying use CT scans and bone scans to monitor response to therapy. What's wrong with CT scans? Well, RECIST criteria don't work. Now, this patient is getting treated with Herceptin, pertuzumab, and Zomita. Here is the T1, and here's the CT scan. But you know, this was called stable, this was called stable, and this was called stable. But look at the MRI, and you can clearly see this patient has progressed. Has progressed. There's no doubt about it, right? And how much is pertuzumab cost exactly? Okay, let's look at that. 1 year of cost. Herceptin by itself, 55,000, and we're flushing money down the toilet, but we're also putting our patients at risk. Another example. Here's a patient who gets treated with standard of care. I mean, this is in my institution, standard of care, right? Here is one metastasis, for example. This CT scan gets called normal by one of my colleagues, so prospectively, okay? This I call abnormal. Let's repeat the MRI. And you know what? The tumor volume had gone up from 50 cc's to 500 cc's, right? 500. 1 log more of cancer. Why? You know why? Because we were using shitty scans. These shitty scans are CT scans and bone scans, right? We have no idea. We have literally no idea what happened between time point 1 and time point 3. No idea. And you know what? We put this patient at a disadvantage. Instead of being able to give less toxic treatments, we end up giving more toxic treatments when you really might have had an opportunity to salvage this patient. And that really is not acceptable. The other thing is that CT scans, it's very difficult to distinguish sclerotic from lytic progression. This is the same patient. The PSA is the same. 1 year apart, right? You can't tell whether there's active disease or inactive disease, what the hell is going on in this bone. You know, we guess. Yeah, I guess all the time. I think, well, it could be this, it could be that. But really, do we know? We don't know. Why? Because CT scans don't show us tumor, right? They show us the stromal reaction to the presence of cancer, and it's all mediated by these cytokines. So it's, you know, it's like a magic. And this is just crazy. So it's in this framework that we're thinking about doing a multi-parametric assessment of the bone, and this is where whole body MRI comes in. So whole body MRI is a functional technique, as Frederick has just said. Not only has it got diffusion as the functional component, but it also has fat fraction, which is easy to measure using a 2-point Dixon technique. So here's another example. I mean, I don't know how many examples you need to see. Look at the date. 5th of September, 7th of September. How many metastases do you see here, and how many do you see over here? It's just impossible. I mean, I don't think any of you should be under any illusion that you are doing a good job when it comes to metastatic disease. Now, the nice thing is that the whole body MRI technique, if you do a detection protocol, it takes about 30 minutes. If you do a response assessment protocol, it takes about 45, 50 minutes. And you can do this at 1.5 and 3T, and this one was done at 3T. And the quality of the images are great. I mean, you know, these are fabulous images. And this can be done within 45 and 50 minutes. The nice thing is, because of the resolution, you can actually zoom in and do localized views if you need to. So in this particular instance, there was a lesion here that I was somewhat concerned about there. I was able to zoom in, and that is just fat, poor bone marrow. That's not metastatic disease. We can do some localized views and show in this particular instance that there are lymph nodes in the pelvic side wall. So this is what's today called M0 CRPC, which is very suitable for these two new indications that were just introduced last week for these new drugs. You spot this, you lengthen this patient's life by 2 years. This is the consequence of what we do. So the whole body MRI technique, the diffusion sequence alone, is standardized. The METRAD standard has been published, and we'll talk about that. Potentially, every one of you could do it, and it's quantitative. And it correlates with biology. So here is a very nicely done study where the bone marrow is drilled. You look at the fat fraction in that area, you look at the ADC, and you look at the signal intensity, and you can correlate with the number of cells in the biopsy tract. So lower ADC, higher signal intensity, lower fat fraction, more cells. Okay, so this is high-level evidence. Not only that, it's a quantitative technique, so you can segment out the bone marrow. So here, for example, you can see a pre and a post, and you can see how the histogram flattens and moves to the right. Sorry, moves to the right. For you, it's that way. The cell kill is responsible for this shift. Okay, and then you can back map this onto the body. So, look at this particular patient. You can say there's still tumor that's alive in these areas and tumor that it's dead. Now this traffic light system, your clinicians will love it. I mean, I get people say, will you please send this traffic light map to me? But you know, you can drill these bones and you can show mutations in those areas. So for example, if this patient was drilled here on the left-hand side and here, and you can see it's got high signal intensity and a high B value, low ADC, drilled and we found a BRCA2 mutation. Okay, gets treated with a olaparib agent. Patient responds, the ADC goes up, cell kill. And you can see here, we get a new spot that appears later. We drill that bone and we show that the BRCA mutation has reversed. This is precision oncology. This is saying, what is going on here? Can I action mutations with new drugs? We know the ADC value has great reproducibility. So here's 9 studies, 141 tumors. A 12% change is real. 12% change. So the average ADC in a tumor, say 1,000, the 12% is 120, right? That's a good figure to keep in your brain. And not only in single organ studies, but also in whole bodies, in volunteers, 14%, prostate cancer metastases, 16%, whole body MRI, you can see the median is 6%. So 12%, 13%, 15% is a good figure for you to say, this is a figure that represents change. Not only that, but the inter and the intra-observer variability is very good also. It is better than bone scans. And I think there are prospective studies like this one. There are meta-analyses like this one. Really, after all these years, are we still using bullshit scans, bone scans still? Really, I think we need to be careful. Really, we need to move into the 21st century. And you know, here's another meta-analysis. You know, there's been so much evidence out there. And you know what? A lot of clinicians come to me and say, you know, my patients, they don't like whole body MRIs. They feel like they're in a tomb. I hear this all the time. So I said, okay, let's ask the patients, right? Don't talk to the doctors. We know these guys are biased. Let's talk to the patients. And we did a patient questionnaire on 2 occasions during a clinical trial. How acceptable is this for you? And you know what? Satisfaction, good or very good, 100%. Willingness to repeat the scans, very good. You know, some people even preferred the MRI to the CT scan. Patients with metastatic disease will undergo this. And here's my activity, showing you how things have changed over time. So if you take the 2 key indications, breast and prostate cancer, one of our indications is to rule out metastasis either in high-risk patients, breast and prostate. And here's an example of somebody with a recurrent tumor in the prostate gland. We're looking at the whole body to see if there's metastatic disease, and this guy doesn't have it. Okay, so he just has local recurrence in the prostate gland, and here is the high B value image. We use it in pregnant women with breast cancer to stage them. So here's a lady, unfortunate, 34-year-old, she's got triple negative breast cancer, she's got multifocal tumors in the breast, axillary lymph nodes, internal mammary lymph nodes. Here's the baby, here's the placenta, here's the head. This is an ideal technique to stage her. You can see she gives birth, we give chemotherapy during pregnancy, and then unfortunately, you can see here that she has reconstructions. These are reactive lymph nodes. She then relapses, has axillary nodal disease here on the left, bone disease, and then, you know, we couldn't rescue her. She had triple negative breast cancer, develops liver metastases, bone metastases, and unfortunately passes away. So response assessment is a really key indication for us. And you know what? If you're going to do anybody, please do castrate-resistant prostate cancer. Please, please. I mean, there are thousands of patients that need this. And the reason I say you should do this indication is because we know in castrate-resistant prostate cancer, 20% of patients will develop radiographic progression when the clinical is not progressing and when PSAs are not changing. In other words, 1 in 5 patients will develop progression if you look at them and the PSA is normal or not changing and the clinical findings are not changing. 1 in 5. And here's a typical example. This guy goes to gym twice a week. Gym twice a week. Look, he's developing cord compression. I'm saying, what the hell are you doing? I told you this patient was progressing, in February, and now we're in May, and you still haven't changed the treatment. He's now got cord compression. This is a typical example. We see this all the time, 1 in 5. And you know what? It's in the guidelines. Myeloma, Leaf-Romani syndrome, some guidelines in some places for melanoma. Somebody said to me, prove it. Okay. Show me that you are better than CT scan. And you know what? We have to do what's called a non-inferiority study. And we did a prospective non-inferiority study, blinded reading, etc., etc. And when we did this, we found progression resulting in a treatment change in 2/3 of patients only on MRI. There was not one patient where the CT scan showed progression and MRI did not show progression. Out of 43, not one patient. Okay. And here's an example. So this patient on MRI is progressing. On bone scans, it says disease extent unchanged, no increase or decrease in volume. And that CT scan on the bottom on the right prospectively read and said no change. Right? So I'm saying change this treatment. The volume is doubled. This is prospective data. And we are beginning to make an impact in the clinic. So here is 101 patients. And what we did was we took their CT scans and the bone scans and we said in the clinic and said, okay, what impact does it make on a face-to-face? And you know what? It's the MRI detected more cancer in 50% of cases, right? There were differences in 1/3 of cases in the response assessment category. So this number keeps coming out, right? 1/3. When systemic chemotherapy was changed, 35% was only due to the MRI. So you're altering the thinking of your oncologist. So there are standards that have now appeared, and here are the references. Here is the protocol, which is in the METRAD standard. I encourage you to look at this. There's a core protocol detection and a comprehensive protocol for response assessment. We have standardized data collection. So these sorts of sheets, how to fill in these forms, are now available. Here's the one for breast. Here is the one for prostate. And we have given you criteria on how to assess response, how to record this as well. Okay, so I'm going to switch over this criteria, and this is typically what we would provide to our clinicians at the moment. So my predictions are that MRI will replace current, ineffective, indirect, wasteful. Say that again. Indirect, ineffective, wasteful methods of assessing the bone marrow. We really have an opportunity to change the way clinicians think about their patients and their treatments. We can promote precision oncology. We can promote precision oncology because if we do our scans at the right time, we can enable switching at the right time. I just want to leave you with this image. Here's a patient who we're trying to do precision oncology on. You see, we're treating her with hormones. You see, it's not a great response. She relapses. We switch treatment. She responds a bit, then relapses. Then we switch treatment. You can see she then responds for a short time, and then she relapses and then dies after developing metastatic liver disease. In this short period of time, we managed to get 3 treatments into her. So you can see how we tried to use imaging to try to get the most number of treatments that could work into her. And one of these treatments worked. Do you see that? In fact, all of them did work if you look very carefully, but the capecitabine worked the best. But I disagree here with Frederick. I think we're still incomplete in terms of validation and qualification. So that's my final point. Thank you very much indeed.